Bill, in order to achieve cure from rectal cancer, some patients end up with permanent stoma following abdominoperineal excision. And since Miles described abdominoperineal excision is over 100 years, and now we are doing a little bit change the same surgery. Why do we need to change this conventional APE surgery?
Well, I'm not actually a Miles fan. He somehow got his name stuck on this operation, but I think the more canny thinker was the great Kocher, Theodore Kocher, who was professor of surgery in Bern in Switzerland. He originally described the posterior approach and felt that the surgeon's understanding of what he was doing and ability to do the most challenging part of the dissection in the very low cancer was to put the patient face down in the prone jackknife position, then to remove the coccyx. I was actually taught this in Poland by Marek Bebenek, who also likes to remove a little bit of sacrum. Neither things do much harm. You don't need to take away a large amount of skin, but with the patient face down and a decent hole from the removal of the coccyx, you can then draw out the bowel, the abdominal part of the operation being previously completed and the patient closed up, the turnover. Now we're looking down into the back of the prostate, the vesicles, and we can use the specimen, rolling it from side to side, folding it down so that we can dissect the front of our specimen carefully off the back of the prostate, then go through that very awkward part which is called the perineal body. Surgeons get a little bit lost down there because they like planes, and there is no plane where the transverse perineal muscles cross and form this curious fibromuscular body which you can actually see on an MRI, and which we surgeons, when we come to it, we wonder whether we're cutting through the prostate or what we're cutting through. This is perhaps a good, lovely example of how turning the patient face down has enabled a whole new approach in the West, if you like. In Wrocław, in Poland, they've been doing it this way for years. But in many parts of Europe, most parts of the world, the synchronous combined excision with the patient on the back has been preferred. But the really exciting thing that has come from turning the patient over is that we've been able to identify positively the nerves on which penile erection depends, sexual function in the male, and presumably also the nerves on which the clitoral function in the female depends. We actually can see these neurovascular bundles so carefully preserved by the urologists. We see them in a totally different way. Very exciting step forward, that. And to me, that improved access, originally described by Kocher, then forgotten about, then brought back more recently, I think that is enabling us to fill better APE, extra levator APE specimens with a nice muscle wrap around the really vulnerable, dangerous lower part. The cancers being around 3-4 centimeters from the anal verge, really just a danger from that surgeon going into a waste inside the levators, following the holy plane too far down within the levators, and failing to get a clear margin because they haven't had a nice levator wrap to protect that vulnerable part of the specimen. So I think that's pretty exciting change, which is all incorporated in one of your discs.
Right.